Okay, so I will start. The title of the topic is, as Professor Yakopoulos said, slowing the progression of diabetic kidney disease. And at first, I would shortly present some data about the prevalence. Worldwide, about 700 million people developed CKD in 2019. Here we can see the global prevalence, that is at 9.2%. This is country specific, as we know, and it has a variation across countries and across continents. The highest prevalence is seen in the Eastern and Central Europe and in North America, in the Caribbean, where it reaches about 12%, and in Africa. Unfortunately, the second global emergency is also diabetes, as we all know. Here we can see an even higher prevalence. About 150 million people worldwide were affected from diabetes mellitus, and those are data from 2017. Indeed, diabetes mellitus is the most common cause of CKD, and if we go to the incidence of ESRD, of end-stage renal disease, the patients that need substitution of their renal function, we can see here that diabetes accounts for about 50% of all end-stage renal disease patients. As we can see, the conditions are closely linked and very high prevalent in all countries. And the worst is not the prevalence, but it is also the interaction. Diabetes mellitus and CKD are both strong cardiovascular risk factors. If we can see the 10-year risk of cardiovascular death in patients with CKD, as we can see here, is about 4%. And it is as high as 14% in stage 4 and 5 of CKD. That means that CKD is an equivalent to cardiovascular disease. And if we can see the interaction of the comorbidities, it's getting even worse. Here is the relative risk of death in patients with CKD without diabetes and without CVD. It is at 2.3. This risk increases to 10 in patients with CKD and diabetes, but without CVD. And patients with all three conditions have a relative risk of death even at 50. As we can see, all these comorbidities interact, and the effect is not additive, but it is multiplicative. So we have to intervene. This is also known in many medical specialties, and that for all doctors that are treating those patients are aware of the problem. And so we can see here in the cardiologist guidelines, in the European Society of Cardiology guidelines of 2019, it is recommended, and with a high level of recommendation, 1A, as you can see, that all patients with diabetes have to be screened annually for GFR and UACR, urine albumin to creatinine. So all diabetics should be screened annually. And there should also be a tight glucose control with a target of glycosylated hemosphere above 7%. Coming now to the slowing of the progression of this condition, indeed, until 2005, that means for the past 15 years, we did not have many drugs to slow the progression. We knew that we had all these patients with progressive CKD. What we could do, we could not do many things. We had the RAS inhibitors. We recommended some lifestyle modifications, but that was it. Fortunately, in the past 2 years, due to many studies that had primary cardiovascular outcomes at first, also many classes of new drugs have come also to nephrology. And now we have many agents and many things we can do in lifestyle modifications to help slowing this progression. As for the lifestyle modifications, we always told to our patients that they have to have low protein diets, weight loss, low salt intake, tight blood pressure control, and all these things. Nowadays, we have the plant-dominant low-protein diet that was really a revolution in these diets. They can be administered in patients even with a GFR less than 15, and they have shown many beneficial effects in trials. But they need experienced dietitians, clinical dietitians, that can supervise these programs. Coming now to medications, we had the RAS inhibitors and the ARBs, of course, but fortunately, the past years, we have also many primarily anti-diabetic drugs that have shown, as I said before, in cardiological trials, the beneficial effects in renal protection. I will start with the RAS blockade. We all know very well. We have these studies, the RENAL and the IDNT. They were published about 2005, I think. And of course, they have for long shown their protective effects. Of course, in the guidelines, in the 2019 guidelines, the recommendation is very strong. As you can see, class 1A, a RAS blocker, either ACE or ARB, is recommended for diabetic patients and not only, and particularly in the presence of proteinuria, microalbuminuria, or LVH. I think we all know this. There is no single patient treated by a diabetologist, a cardiologist, or a nephrologist that can tolerate and has no contraindication and does not take one of those inhibitors. Coming now to the anti-diabetic agents, we have many of them. I will just focus on two categories. That does not mean that the others have no renoprotective effects. We have also seen renoprotective effects with the oldest drug of those, metformin. Metformin is a very cheap drug. We know it for very long. It has many beneficial and pleiotropic effects, also for the kidney. Okay, we have to lower the dose at the GFR below 50 and discontinue below 30, but we all know that until it comes to that, they have beneficial effects taking metformin. Starting with the SGLT2 inhibitors, we had many things in the previous table. I don't describe the mechanism again. Okay, we all know they inhibit the proximal tubule glucose reabsorption, leading to glucosuria and natriuresis, and this is the main mechanism, but they have also many others that finally lead to renoprotection. We have here all the RCTs assessing different SGLT2 inhibitors. Indeed, the first studies had other endpoints, primarily cardiovascular endpoints, heart failure trials, but there were also secondary endpoints that had shown that this class of drugs is renoprotective. We had with canagliflozin the CANVAS and CREDENCE trial, with dapagliflozin the DECLARE, DAPA-HF, DAPA-CKD. With EMPA, we had before the EMPA-REG and the EMPA-REDUCE trial, but those that had primarily renal endpoints were the CREDENCE and the DAPA-CKD. And most importantly, the DAPA-CKD also included patients without diabetes. I will just describe the DAPA-CKD study shortly, because it was for us as nephrologists the landmark study, and I will tell you why. It included a total of about 4,300 patients, diabetics and non-diabetics. As you can see, there was a broad range in GFR between 25 and 75 milliliters per minute, and also a broad range of albuminuria, from 200 milligrams to 5 grams. The renal specific composite endpoint was a reduction of GFR by 50%, or ESRD, or death from renal or cardiac cause. And as we can see here in the graph, compared to placebo, really, indeed, in the dapagliflozin group, there was a reduction in this renal specific composite endpoint with a hazard ratio of 0.56. The non-diabetic patients included were 34%, and that what was the most important point for us as nephrologists was that also in this group, the renal protection was sustained. That means that this composite primary renal endpoint was also reached in the non-diabetic group. And this opened the door and the way to the very, very broad use of these drugs by us as nephrologists, and also in non-diabetic patients. And this is why this editorial was published in 2020, as you can see. SGLT2 inhibitors offer cardiovascular and kidney protection in both diabetic and non-diabetic CKD. Additionally, as we all know, they improve glycemic control, and this makes them first-line therapy for CKD independent from diabetic status. Coming to the recommendations and the guidelines, the KDIGO guidelines for us as nephrologists have a very strong recommendation, class 1A. SGLT2 inhibitors should administer to patients with diabetes type 2 and a GFR higher than 20. As we know, there is an expected decrease in GFR for the first 8 weeks. It is known, it is similar to the class effect of the RAS inhibition. It is tolerated until it is about 25 to 30%, and this should not be a reason to discontinue the drug. It is expected, and then in the future, there is a reduction in the slope of GFR, and the renoprotective effect finally results in gaining of renal function or stabilization at least. Once it is initiated, we can continue it. Here they say it is reasonable to continue it even if the GFR falls very low, below 20 milliliters per minute. But in a sub-analysis of the DAPA-CKD, they showed that it can also be administered until the patient enters dialysis. And coming to the cardiological guidelines, there is also a strong recommendation. Here it is class 1B. SGLT2 should be administered to patients with diabetes with a GFR from 90 to 30. Coming now to the next drug, there are also the GLP-1s. Here, there is a lack of renal primary outcomes in patients with GLP-1s, in patients with diabetes. But if we see the mechanism of action of those drugs, they have also many renoprotective and pleiotropic effects. They increase insulin secretion, they increase insulin sensitivity, they also lead to natriuresis, reduction in RAS activation, have also an anti-inflammatory and anti-fibrotic effect, and reduce weight. All these drugs finally have a central mechanism that leads to decrease in intraglomerular pressure. That is why they also have the slight increase in GFR, and they show renoprotection. But with this class of drugs, studies with primary heart renal endpoints have not been published yet. There are positive results in studies with primary cardiovascular endpoints, and I think the end of the story will be that there will be trials with heart endpoints, and they will come to our medical armamentarium, but a little bit later than the SGLT2. We still lack the heart renal endpoints. There is the multi-center flow study ongoing. It started about 2018, I think, and investigated the efficacy of semaglutide in renal endpoints in patients with moderate and severe DKD. Semaglutide was administered subcutaneously once a week, 1 microgram per week, versus placebo for more than 5 years. The study aimed to recruit more than 3,000 patients globally, and the inclusion criteria was, as I said, moderate to severe DKD. They should have a decrease in GFR and also proteinuria. The composite primary renal endpoint, as you can see, is a hard endpoint, decrease in GFR more than 50, ESRD, death from renal or cardiovascular cause, pretty similar to all those trials with SGLT2. And the study is about to close to finish and has the first published results at the end of the year, beginning of next year. Until then, we have some studies with real-life data. This is one study from a Spanish group. It again investigated semaglutide in type 2 diabetes with chronic kidney disease. A total of 122 patients with diabetes and CKD were included. And as we can see here in the graph, it had many beneficial effects on diabetes, a reduction of glycosylated hemoglobin, weight loss that was pretty high, better control of blood pressure, but the renoprotective effect was shown mainly in terms of reducing the UACR, more than 50%. But as I said before, there is a lack in the real hard renal endpoints. And this is why we await the results from the flow study. As for the MRAs and finerenone, I will not say anything more because later on there is a lecture by Professor Sarafidis. Just to mention, this drug can also be added to the RAS blockade, to the SGLT2, maybe to the GLP-1s if they come also after the study results. And on top of this, we can also add the MRA in patients with diabetic nephropathy and GFR more than 25. And with my last slide, I would like to draw the attention. We have many drugs, all of them lower the intraglomerular pressure and have this slight increase in GFR. And this is the mechanism by which they ask their renoprotection. But we have to keep in mind that in the acute setting of hospitalization and especially of volume depletion, we have to temporarily withhold these drugs because, and we should also inform our patients maybe to do so by themselves if they have volume depletion, if they have fever, if they have an acute illness, because I don't know for you, but we can see in our everyday clinical practice with all these drugs that interact and have and share some common mechanisms, we see many hospitalizations of patients with AKI. Cardiologists are more aggressive than nephrologists. We know that we have to start these drugs slowly and maybe not all together and temporarily discontinue them. But maybe we should also draw the attention of the other specialties because we see increasingly patients with AKI with all these combinations. We have to protect the kidney, but in the acute setting, we have to lower or temporarily withhold them. Thank you.